Looking at cancer in the United States, for women, the most highly prevalent cancer is breast cancer, followed by lung and then colorectal. For men, most prevalence is prostate, followed by lung and colorectal as well. Overall, the leading cancer that is going to cause cancer death is lung cancer. So, this is something that can affect either gender and has a multitude of factors for why somebody might have lung cancer. But one good thing about more research that has come out in surveys is that according to the American Cancer Society, 70% of people are surviving at least 5 years after they have had a cancer diagnosis. So it could be any cancer. They are also living longer expectancies. So, with that, of course, every cancer is a little bit different, and there are some out there that are less researched and their treatments just aren't as effective. But a lot of the common ones, especially the ones you see on this slide here, are getting more research in them, understanding how they interact with different treatments and more effective and aggressive types of treatments so that we can attack those cancer cells early and give them a prolonged life. So that's great news to see that with their last survey and analysis that things are increasing for patients. We'll talk about both breast cancer and prostate cancer in this course, but first we're going to start with breast. 1 in 8 American women by the age of 70 will be diagnosed with breast cancer. The risk factors are a long list here, but being female is going to have 100 times greater risk of developing breast cancer, and that is due to the structure of our breast anatomy as well as the hormonal factors within there. Increased age will also cause an increased risk because you've been exposed to more carcinogens throughout your life as well as different hormonal factors. And then with race, we are going to see that there's a higher prevalence in white populations. And usually, Black women are going to be more likely to have an advanced disease by the time that they are seen. And there's a higher mortality rate in that group as well. And a lot of that's due to what access to healthcare that they might have, as well as just different economic statuses and things like that. So there's a lot that goes into that. And remember, we're looking at the entire American population, not just, one area. With weight, if you have a higher body mass index, that is going to increase your estrogen. And estrogen is actually one of the hormonal factors where if we increase the amount of estrogen in our body, a lot of cancers will feed off of that estrogen to help them grow. If you have early menarche, which is the start of your period, or if you have a late menopause, meaning that you've had a period for longer, then you are at an increased risk just because, again, more hormonal factors. You started early, maybe when you were like 11, 12, and then you continued with that all the way up until menarche's usually around the age of 50. But if you extend into, having periods until you're 60, that's a long time frame for a lot of that hormone to be cycling through your body. If you are nulliparous, which means that you have not had any children at all, if you have received HRT, which is hormone replacement therapy. So we do see this in people that are at menopause age and they're losing their normal estrogen and they're experiencing some side effects due to that just naturally. And so a physician may recommend to have hormone replacement therapy to help with some of those symptoms that they are experiencing. But again, you're increasing your hormones that are cycling through your body. And so therefore it does increase your risk slightly. Also, if there are any kind of gender changes with certain populations, if you are transitioning and you are utilizing hormones on the female side of things, so if you're increasing your estrogen or progesterone, that can also be a factor that increases your risk for breast cancer. Breast pathology, if you have had previous history of having like an atypical ductal or lobular hyperplasia, which just means that you have cells that are looking a little bit different. They may be growing differently, but they're not truly cancerous. That can be a very early sign that something may occur later on. If you personally have a history of breast cancer within that same breast or even in the opposite breast, you can have a greater risk. Genetics I know a lot of people kind of put a very negative connotation on the BRCA genes. So BRCA, BRCA1, and BRCA2. And while this is a very good indicator, so let's say there's a group of 5 women, all 5 of them get tested, only one of them has the BRCA gene. That one person does have a substantially greater risk of having something like breast cancer or ovarian cancer later in their life. But when you look at the 1 in 5, that's only 1/5 of that group. And that's actually way higher with that number than what is seen in the United States. So the amount of people that actually have the BRCA1 or BRCA2 gene is very small. It's a very small group. But if you do have that, then you do have a greater risk of having the breast cancer later on in your life or ovarian cancer. But I don't want you guys to think that BRCA1 and 2 is like extremely prevalent. Genetics based off of this is actually a very low percentage of the people that get breast cancer. Lifestyle. So if you use a lot of alcohol, you use tobacco, if you actually smoke, and then if you have a very sedentary lifestyle, all of those things are going to affect your hormone production. They're going to affect your body's ability to fight off infection, as well as you are introducing carcinogens throughout your life. So the mixture of those things and then the sedentary lifestyle is you're not building your body up for success. All of those things are having an increase of breast cancer. Radiation exposure, if you were exposed to radiation at a very young age, and I'm not talking about like you broke your arm and you got, a wrist x-ray or a forearm or a chest x-ray. All of those things are very, very minimal. When I'm talking about radiation exposure is if somebody has leukemia or lymphoma and they come to us and they are being treated for that leukemia or lymphoma within the chest region. Sometimes we do a very, very high dose of radiation for either one of those cancers. And so with that being said, we want to make sure that they know and the parents know that there is going to be a greater chance of having a cancer later on in life because it's a substantial amount of radiation. It's not just a small wrist or a chest x-ray. So those are some things to think about with risk factors for breast cancer. I wanted to cover a little bit of anatomy of the breast. So the breast tissue is going to sit anterior to our pec or pectoralis muscle. So we can see that demonstrated on the side here. Let me get a different color that might stand out a little better. Let's do blue. So we have the pectoralis major muscle, which is demonstrated here. It goes all the way down. And so it's going to look more kind of like a triangular shape from this lateral. It is very, very long, elongated. When we do mammo imaging, we're going to be looking at the breast tissue and we want to see a good portion of that pec muscle to know that we got all of the breast tissue that is sitting in front of it. So our breast is going to sit from the clavicle. So you can see the bottom of the clavicle here. It's going to extend from there all the way down to what we call the intramammary fold or the IMF. So it's going to extend down in front of that pec muscle all the way down until we get to this fold where the breast tissue kind of hangs a little bit. So to there is going to be what we consider breast tissue, and then obviously everything anterior to that. From left to right, which this image is amazing for that, is we are going to see it from the sternum. So your sternum is your hard chest bone, and it's going to go from that medial aspect all the way over to the axillary tail, which goes up into your armpit. So we see that the breast tissue extends quite a bit from left to right and up and down. So we have to make sure that we understand where those are, especially when we are doing our simulations. We need to know from start to stop locations when we have gotten all of that breast tissue. We are going to see there's going to be about 15 to 20 lobes that are sitting within adipose tissue. So all of this kind of yellowish color you see, and it's represented down here, that is adipose tissue. So it's more of like the fatty substances that make up the breast. Our lobes are then right above that label here. It's going to be what I think of like the grape structures. So if you think about a bundle of grapes, you're going to have your main stem where then everything kind of branches out and they have their own little clusters. So where those clusters are kind of consolidated into bigger areas, those are what we would refer to as the lobes. Okay. Inside of those lobes, we are going to have ducts, so the branches of the grapes that are going to connect them to each other and then all the way back to the main stem. We have alveoli that, so similar to the lungs, is our last stop where we're going to see that the production of milk is made. So milk is made inside of these alveoli, which is labeled up here. So you can see they're going to be like the actual individual grape structures inside of there. So there's a bunch of them kind of in the same area. And we have numerous amounts of alveoli within each lobe. Then they are all connected to ducts. You can see that here. So those are basically like the little vines or the stems that are going to take it all the way back to the main stem up in the front. So the ducts will take that milk that is produced at the alveoli and it will take it through that breast tissue to the nipple. Okay, and the nipple is where we allow the milk to be excreted. So this occurs, lactation typically occurs, obviously. It develops during pregnancy, and then after you've given birth, then that's where the milk is truly expressed. Some people throughout their lives may experience some type of lactation, even if they are not pregnant. And that just has to deal with the hormones and the production that the brain is telling them to make milk. And so sometimes there can become some miscommunication there. But most people don't experience that until pregnancy. So outside of then, we still have all these structures. They are just not functioning in the way that they would for lactation. So everybody, all women are going to have this. It's just a matter of when it is put into function. The most common clinical presentation of breast cancer, especially early stage, is going to be asymptomatic. So they don't have any pain, really any issues, and sometimes they don't even have a palpable mass. But then they go in for their yearly mammogram, and when they get the imaging back, they say, oh, well, there's this kind of consolidation of area that's looking a little bit what we call suspicious. So after this, then they would receive a biopsy to confirm whether it is cancerous or not. Once the patient does start to see and feel signs, some of those physical signs could be that the tumor is large enough for the person to palpate. And I would say that's a fairly common one as well, is I would highly recommend to all women to do a breast exam monthly around the same time. Don't do it near your period because it makes your breast tissue more sensitive. But utilizing some different methods to just feel your breast tissue and know what it feels like. And so that way, later on in life, when you may be concerned that you have a mass, you know what your standard or your baseline is. So then you can say, this is new, this is different. And that could help save somebody's life if they are familiar enough to know that maybe they have more dense breast tissue. And if you do, that means if your breast tissue may feel just like a little bit more lumpy, just because your lobes are a little bit more prominent than some others. And so if you know that, then you can be aware that, okay, this is my baseline. When later on, maybe you notice that one of those lobes is larger than normal and you haven't had any other recent changes to your health history, then I would say that is something you want to go in and see your physician about. So the earlier that you can get diagnosed with something, the faster they can get you treated and the better outcomes possible. More advanced signs is if you have a very large mass that you just can't miss. And so this could be more of a, hey, I'm putting on my t-shirt and I can just feel as my arm brushes in that area. I can feel something on my arm instead of it just being a small mass. Also, it could do an abnormal breast shape if it's large enough or causes enough issues. You can have what's called nipple retraction, where if the breast has a mass in it and it's actually really pulling on the surrounding structures, your nipple could actually retract in. So it basically kind of creates a little divot where the nipple should be. It just kind of pulls that tissue in. And so that's indicating to us that there's something, with going on with under the surface. Discharge, usually most discharge, you would think it's kind of weird, but you would think like the colors would be concerning, but some people can have like a natural different color discharge, or even if you have just a regular infection in your body, you can have different colors of nipple discharge. It's not usually unless we see blood that we are concerned. So you can have lots of different colors, green, some can even be like brown or black, and they're usually not too overly concerned about it being cancerous unless it's bloody. That's probably more than you wanted to know. But anyway, skin erythema or thickening. So if a mass is large enough or just causing structural issues, your skin can start to turn very red in that area, and it would only turn red really in that location, not over the whole thing. You can see some thickening in the area of the skin, so it just feels different to the touch. There is one type of breast cancer, it's called inflammatory breast cancer, that you might see your whole breast, could be both, could be one, that is very, very red. It feels hot to the touch. It has like a lot of little dimples in it. It's just a very different type of breast cancer. So that can go along with this erythema and thickening as well. Then we have ulceration. So if your disease gets so advanced, I have heard and I've seen this, of the tumor being so close to the superficial components, like so close to the skin, and it gets so advanced, and they're not taking care of the process for it, it can actually cause ulcers in your skin near that. So they can have holes in their skin that are oozing and things like that. So those are very much more advanced disease. The main types you're going to hear about, we have invasive ductal carcinoma, we have invasive lobular carcinoma, ductal carcinoma in situ, lobular carcinoma in situ, and then that inflammatory breast cancer that I just mentioned. So I wanted to add just a little bit more on those main types. So we have the invasive kind and we have in situ. So in situ, I'm going to start with that. It means that they have found a cancerous mass and it is encapsulated, means that there's a whole structure around the outside that's keeping it inside of its structure. So all I can think of right now is we're getting close to Easter as I'm recording this, and we have Easter eggs. So you can fill the inside of an Easter egg with candy. So it's almost as if the tumor is inside of an Easter egg, and so it has this capsule around the outside, and that candy inside has not spread outside of the shell of the egg. So it keeps it within that area. Ductal carcinoma in situ is referring to the fact that it is cancerous, but it is stuck inside its little capsule, and it's found primarily within the ducts. So it's in the ductal areas where it's transferring all that, the milk where it's supposed to travel through. In the ducts is where we see that cancer. Lobular carcinoma in situ, again, is this Easter egg where it's encapsulated. That stuff is inside of it still. It hasn't gotten out of space yet, but it's more in the lobe rather than the duct. So it's in more of the grape tissue that is outside of the different structures. Invasive ductal carcinoma. Invasive is where we see now we have broken out of the egg. So let's say that you have an Easter egg, it's very old, it's very brittle, and it has now broken open. And so with that, with the invasive ductal carcinoma, we see that it primarily came within the duct, but its encapsulament has now been broken. And so it has traveled outside of its egg and moving all the way around. And it could transfer to our lymph nodes, and it can also go into the bloodstream and be transferred throughout the body as metastatic disease. Same thing with invasive lobular carcinoma. We just see that now the tissue is the lobes where we have found that carcinoma. So again, it's broken out of its egg and it has spread outside of its encapsulament in the tissues within the lobe. How do we detect breast cancer? So one of the most common ways, especially in early stage disease, is through mammogram. So we are going to see patients that are usually 40 to 45, starting their first mammo, depending on what their physician recommends and their preference. Mammo does use ionizing radiation, so that's something to take into consideration for the patient. We'll do two different views for standard imaging. We do craniocaudal, which is CC, and it's looking from top of the breast down through it, so it's more of like an AP view. Then we have our medial lateral oblique. So this is a somewhat of a lateral view, but we're doing it at more of like a 45-degree angle. And the reason for this is because remember when I told you that our breast tissue extends from the sternum all the way up into the armpit? That is more of like a diagonal or oblique line. So we're trying to line it up where we get the most breast tissue. So if we rotate our detector over and we're at about like a 45-degree angle, we can get more of the structure. So up here at the top, this is what our MLO would look like. So we have the breast tissue coming from the up in the armpit and then hangs down, and then we get the IMF or that intramammary fold down there. As you can see here, this is that pectoralis major muscle, and we do our best to try and get as much on both images, which you can see they didn't get as much pec muscle on that second image there, and that is mainly due to the fact that there is more density, and so they may have struggled to try and get the breast tissue pulled out enough due to patient discomfort, or it could have just been a smaller and more challenging breast on that side. Another thing that we can do is we can visualize our imaging with tomosynthesis. So it's 3D. A lot of mammo has just straight gone to this because insurance covers it better than they used to. But we still do our CC and we do our MLO, but instead of just taking a one straight shot of an AP and a lat, instead it takes a whole bunch of little images going over the top of the patient. And so we're still in that CC or MLO position, and it just keeps taking small pictures throughout the whole however many degrees. And so what helps with this is that the radiologist then can scroll through all those images and make sure that they don't see anything that stands out to them. Sometimes with the regular CCs or MLOs, some of the dense breast tissue can line up on top of each other. And if you look at it just in a standard AP or lateral view, everything overshadows itself. And so you think you see something, but if you have the tomosynthesis, you can play through every single individual slice and see, is this really a mass or is it just breast tissue that's laying on top of each other? There are some other specialty views that we can do because we can evaluate these masses. Masses are usually caught on the CCs, MLOs, or 3D. Calcifications we typically can see on these, but if they are microcalcifications, which are the ones we're usually concerned about, which means they're just really, really small, tiny little specks on our image, if we see those, then we may have to do what we call magnification views. So it just magnifies the tissue in that area so we can better identify the microcalcifications. And then they can decide if they want to do a biopsy after this. Ultrasound is another modality that we can utilize to help detect breast cancer. This is usually done in younger patients, so below the age of 40, and even sometimes if we think that there might be something within the mammo, but we're just not 100% sure what it is, we can order like a follow-up ultrasound as well to make sure that it's not like a cyst. But with the younger patients, our goal is to reduce their amount of radiation dose that they would receive with their mammogram. And so if we can see something and it looks suspicious on ultrasound, they still may order a mammo just to see it in a different aspect. Or if they see it on ultrasound, they may just go ahead and biopsy it from ultrasound. That way that they can evaluate it in that way. But this patient has some calcifications within the breast tissue. So these are big ones. These are not micro, these are macro. These are big ones. So these ones are ones we wouldn't really be concerned about. What we may be concerned about, though, is this overlapping density of breast tissue, trying to identify if this is more just lobes or if it is truly an issue. And when I'm looking at this here on the backside, I see a lot of fatty breast tissue. And so I think this patient inherently should have more fatty within that area, but we're seeing a really strong density. So they may have ordered a follow-up ultrasound to make sure it wasn't a cyst. And then if it's still suspicious, they'll biopsy it. One thing about ultrasound is that we cannot see calcifications on mammo, or at least not clearly enough to identify, but especially they cannot see microcalcifications, and those are concerning to us. So that's why the older, after the age of 40, we do recommend doing a mammo first, and we can get extra information from an ultrasound. But typically with younger women, we do ultrasound first. It's kind of the standard. And then over on the right-hand side, these are ultrasound images. So we are able to see they're looking at this structure here. And down here, they have put color on top of it to evaluate and see what that structure might be. So I am not credentialed in ultrasound, but what I have knowledge of is that within here, it is a very dark structure. And so that usually means it's fluid filled. And then at the bottom image, when they have put the color flow over the top, there's not much color feeding the tumor or the mass that we're looking at. So this might just be a cyst. And so as long as the ultrasound tech and the physician are both in agreement that they think it's a cyst, then they will just follow up in a year and verify that everything looks good. But if they're like, I'm still not sure, they may go ahead and do a biopsy on the patient. Another good detection modality is MRI. And so magnetic resonance imaging will cover more breast tissue than the mammo because they are not reduced to just the size that we can get inside the machine, because the MRI holds the whole body. So we can include all the breast tissue all the way back to the chest wall. So we could see some more posterior masses. And it is very sensitive. So we can pick up very small lesions and things maybe we didn't see with mammo or that we couldn't see with ultrasound. And with MRI, one thing that's done a lot is if patients are high risk. So what does high risk mean? It means that risk factor list that I showed you, it means you have more check boxes on that high risk than some other patients. And so if you reach a certain point, the physicians will start to recommend that you maybe get a prophylactic MRI as a baseline so that they know where you're sitting with your breast tissue. Do you have more dense breast tissue? Could it be mistaken for some type of mass? It gives you a good baseline and then they can go from there. One thing about this is unless you meet certain categories or you have like the right insurance, a lot of times it's not covered. And so MRIs can be expensive. But there are some clinics out there that help reduce the cost for these patients that are higher risk. But I think that, in my case, my mom was diagnosed with breast cancer a handful of years ago, and she went through all of her treatment and everything. But I also have a history of my aunt that has breast cancer. I have another aunt that has breast cancer. I have other people along the line that weren't breast cancer, but other types of cancer. And then I have had a fibroadenoma for myself. And so I just am already a little bit higher risk. And so they have recommended that I might end up doing an MRI in the next 5 years. We'll kind of see at my next appointment, but just something to think about because they told me that my insurance will not cover it. I would have to pay for the MRI out of pocket, but it would be a good baseline to have for the future. Just something to think about there. So MRI can be very helpful. It can be a little scary if you get called back right away just because you have more dense breast tissue, but they just want to verify that that's nothing and just have better record for the future. I've mentioned a little bit about biopsy, but let's talk more about the process. So this is what we are going to utilize to help confirm a malignancy. So we do have to take a sample of said mass or tumor in order to evaluate it. So we can do this under mammography, we can do it under ultrasound, we can do it with MRI. And what they're going to do is they are going to first do the imaging to verify the location. Once we find the location of the tumor, then the doctor that comes in, it could be a radiologist that's going to come in and they will determine the placement of the needle. Sometimes they have to put like a kind of a device on top to help them identify exactly how far in from left to right and then in depth they need to go for that placement of the needle. Once they have an idea of where they want to be, they're going to numb that area. So that's where the patient's first going to start feeling some discomfort. So they're going to have the pain from the lidocaine or whatever similar medication that they're using to help numb the area. They will then advance the needle into that location. And once they are happy with where they are placed, then they will pull back a sample. So in a few different types of mechanisms that they can use to take a sample. It's almost like a little trigger where it's going to help capture a portion of the tissue and pull it back out with the patient. Some of them take more of a very small amount of cells, and then other ones take larger tissue samples. But regardless, they're going to take that out and they will place a clip, is what we call it. And some of these mechanisms will automatically go ahead and place a clip. It'll push it in there as soon as they hit that trigger. It'll take the sample and place a clip in that same location. Others, you may have to take the sample and then advance a clip to that spot. So what is the purpose of the clip? The clip is going to be used as a further marker. So once they have the sample, if they confirm that it's a malignancy, when a surgeon goes in to remove that structure, the whole mass, if they need to, then they are going to image with the tissue that comes out of that body and make sure that it has the clip in place, because if the clip's there, they know that they got all of the area that they were supposed to. They typically are going to kind of look at the cells as well to make sure they got a clear margin of everything when they take it out, but the clip is a very good identifier of where they need to be. So as I mentioned, it can be formed with whatever modality visualized that mass the best. So if we couldn't really see it very good on ultrasound or MRI, but we could see it very clearly on mammo, then we would do the biopsy with mammo. Same thing for the other two. Whichever visualizes it the best is how we are going to perform that biopsy. From there, we're going to be doing the staging of cancer. So we typically use what's called the TNM system. T is the size and location of the tumor. We're going to have N for node involvement, so lymph nodes, if it's spread to just regional lymph nodes, kind of local to the area, or if it's spread out, all the way throughout the structure or even to other parts of the body. And then we have metastasis. So this is where we start to see that spread out throughout the body, but we typically will have another lesion or another mass in another area of the body. Very common locations for it to spread are to the bones, to the lungs, to the liver, and another very common one is for it to spread to the brain, where they will see lots of little lesions within the brain. So over here on my image, I have an ultrasound guided biopsy. So the ultrasound technologist will place the probe and help the radiologist find where they want to be. The radiologist will insert the needle and the mechanism will allow them to take a sample. So here's a finer look at that underneath the breast tissue. They have the ultrasound probe on top of the skin. This is their area of view they're looking at. The needle comes in. This is the mass they're looking for. They will take a sample and place that clip. So when we're looking at our stage, you might have heard somebody say, I have stage 3 cancer. How do they make that determination? This is what they're utilizing, at least one of the classifications out there. And so they're going to look at the tumor size. It has them listed out as less than or equal to 2 centimeters for T1. And then it lists out over there if there is involvement with tumor lymph nodes and if there's not, and then if there's any kind of metastasis there. So as we are moving through all of this, it kind of just helps you to look at this and say, okay, if I know that they have metastasis, I know that they have to be stage 4. Could be literally any size of tumor, could have any lymph node involvement, but if it has metastasis to a different location, that means it's stage 4. Our treatment options for breast cancer include surgery, chemotherapy, hormone therapy, and rad therapy. So with surgery, they can perform this and remove the tumor bed as well as the tumor, and sometimes that's referred to as a lumpectomy. Sometimes they also refer to it as an excisional biopsy. If they remove all of the breast tissue, then we are going to call that a mastectomy. It can be unilateral or bilateral. And then we have prophylactic surgery, and that typically is where a patient's going to have both of their breast tissue removed, so a bilateral mastectomy, but it's done in the instance that they have a very high risk of getting breast cancer. So if the patient has the BRCA1, BRCA2 gene, then they may go ahead and elect to remove all of that to prevent their chance of cancer later on. Chemotherapy is going to be an IV medication. Typically, they do have some pill versions as well to kill the cancer cells. It is more of a systemic involvement. So when they have this medication, it's going to kill the cancer cells anywhere that it interacts. So if you have the IV, it's going to go through your bloodstream and try and kill any cancer cells along the way. Hormone therapy, if you have estrogen or progesterone receptive positive tumors, so they feed off of estrogen or progesterone, we call those ER or PR positive tumors. If they are positive, then that means that we can try and do hormone therapy, or meaning we can suppress our estrogen or progesterone, and it takes away some of that fuel that the cancer uses. So if we remove it that time frame, we suppress it, it'll inhibit some of its growth. And then rad therapy, we have to treat local reoccurrence. So we're just trying to prevent, usually we can do this by itself, which we can pretty much eradicate a tumor in some instances. Other times we will do it with surgery, or we'll do it before or after surgery, depending on if they need to shrink the tumor first or if they need to get the tumor out, then we can treat the tumor bed. If they do chemotherapy, we can do it at the same time as chemo. Like they literally could be upstairs getting chemo and then come down to us and then get rad therapy. We could do one before, one after. All of that is literally based on the stage of the tumor, how aggressive it is, the treatment options, and what your physician prefers. With breast radiation therapy, we can treat the entire breast if necessary, or we could just treat partial. Typically, if they have their breast intact, we are usually going to just be treating the partial where they are concerned, and where the mass is in the tumor bed. But let's say a patient has had a mastectomy, we could also treat their chest wall where any leftover breast tissue could remain, just to make sure that they got all the cancer cells. The radiation oncologist will determine what margins we are going to be treating. So if they're doing a partial or a whole breast or the chest wall, but standard treatment is going to be about 4,500 to 5,000 centigrade. And that's going to be over 4.5 to 5 weeks. So they'll break that up. And so it will be daily treatments, Monday through Friday. We have the weekends off to recuperate and be back at it. There is some other options out there called hypofractionation. So if you remember, that's where we are going to reduce the total number of fractions, but give a higher dose each time. So they are still going to see almost 4,000 centigrade to a little bit over 4,000. But instead of the 4.5 to 5 weeks, we're now just going to be about 15 to 16 fractions. So if you divide 15 divided by 5, that's 3 weeks. So they have reduced that. We will then treat either, we can do 3D conformal radiation therapy, we can do IMRT. I have seen some BMAT as well. They can do brachytherapy where they do the interstitial. So they have a good variety of things they can do. The physician knows best. They've obviously gone to school for that and done many years of clinical to identify what works best for different types of cancers and the individual as well. Sometimes within radiation therapy for the breast, we may have to have the patient hold their breath. We call that a deep inspiration breath hold, or DIBH. And so what that does is they take a big breath in and they hold it. We can treat the tumor without the motion of respiratory. So obviously we can't tell patients that they just can't breathe like ever during their treatment, but we can tell them, okay, take a deep breath in and hold it, just like you would with a chest x-ray. And it puffs their chest out enough. It's going to bring their chest wall and the breast tissue away from the heart and the spinal cord. So it's going to allow them to have more distance between them and healthy structures. And we can treat them that way. Whenever we do DIBH or we're treating pretty much anything in the chest region, we are now using that motion management system. So we can do it while they're holding their breath, and we can do it without them holding their breath. If we do it with them holding their breath, we do not turn on motion management until we are ready to treat them. So what we'll do is we'll do a practice breath like right before, but we don't turn motion management on when we're just doing our normal setup because it's not going to match up at all. Okay, but if they're allowed to breathe normally, then we can do motion management while we're setting up. So right before we tell them to take a breath in and hold it, we will get the motion management ready with the light on, and then we'll tell the patient while we are back at the console, okay, take a deep breath in and hold it. And then at that moment, we are trying to make sure that it matches up with our motion management system. And if it doesn't, we did something wrong. Here's just an example that I found for a breast cancer patient. They had stage 1 invasive ductal carcinoma. So that meant that there was a malignancy found within the ductal area, and it was invasive. So it spread outside of its encapsulament. And so it was then, spreading outside of its little Easter egg shell. It was starting to go other places. Luckily, there was no nodal involvement, so it had not truly spread further. And they received a lumpectomy. So they took out the tumor as well as the tumor bed. The radiation oncologist decided to do a 3D CRT treatment, and they did a whole breast treatment. So they treated the entire breast just to make sure they didn't miss anything at 40.05 gray in 15 different fractions. So 15 total days they were treated, about 4,000 centigray. And then some radiation oncologists, they'll decide to do what we call a boost. So it's a really, really small target to the tumor bed. And so we're not treating the entire breast like we would have before, only to the tumor bed to make sure our target gets a lot of dose. They did 10 gray or 1,000 centigray in 5 days after they had received that original 15 fractions. So total of 20 fractions. First was they were getting the whole breast, and then the last 5 they did the tumor boost. Their plan involved tangential fields, which means they're coming from opposite directions and they're basically skimming the chest wall. And they did it at 6 MV. So if I draw my patient's body here, so as they're laying on the table, and this is more like the imaging that we would get, the cross-sectional. So we're going to see this breast come out here, and then we're going to see this breast come out here, right? And I'm going to get different color here. Let's do a bright yellow. Our tangential fields are going to mean that they were trying to spare the tissue that is behind the breast. So we're going to come in and we're going to skim the chest wall as best we can. So this would be one angle where we would get all of the breast. And then we would come from another angle. So a similar, we would do this side, then we'd come back from this side. And it might change just a little bit to try and get this last bit in here. I didn't do a great job of drawing that, but we're going to get a couple different areas where we're trying to get just skimming. It's a tangent, just skimming off of the chest wall in order to make sure we get that whole treatment. This patient did have daily imaging, so they did a CT every day to verify location and determine that they were correctly positioned for the patient. And they had severe heart and lung dose constraints. So what does that mean? It means that we really tried to reduce the lung dose and the heart dose because it's not necessary, but we tried to make sure that they got enough treatment to that breast tissue. So that's why they did the tangential fields, and they did everything they could to make sure that they did it as best as they could with lower dose to the heart and the lungs. Another example, this one's just more advanced disease. This patient had stage 3 invasive ductal carcinoma, so the same type of cancer, but now we see it as stage 3. So this tumor was likely bigger, and we can see at the end of the statement, it says that they have positive axillary nodes. So it had spread out a little bit more than what our previous one did. Since this was more advanced, they elected for a mastectomy. So they removed all of the breast tissue and some nodes. They then went and had IMRT for rad therapy, and they treated the chest wall as well as the regional lymph nodes, and they used 50 gray, or it would be 5,000 centigray, over 25 fractions. The plan was that they did daily imaging to verify location, so this was done with a CT. They had multiple photon and electron fields, and when they did the electrons, they put what we call bolus over the chest wall. Many times when we treat the chest wall or anything superficial and very sensitive skin, we can place, it's like a very rubbery, flubbery material. It looks like the color of skin. It kind of reminds me, I don't know if you've ever seen this, but tattoo artists, when they first start learning, they start on fake skin that's very flubbery. It's a very similar concept to what we use, and it's just like couple centimeters, could be thinner or thicker depending on the patient. We will just place that over the top of the skin, and we usually tape it down during the treatment. And so what that does is it acts as another barrier of skin. So it's going to allow for us to get the dose to the scar and the chest wall without risking anything else occurring, as well as the bolus acts as fake skin. So we have something called our percentage depth dose and how deep they penetrate in, whether that's photons or electrons. And if we have the bolus on top, it acts as a layer of skin. So they assume that it's a further depth. And so they're just able to do a better job of treating the scar from the mastectomy and then the chest wall of whatever possible cancer cells could be left. So here's the process of doing our simulation within breast therapy. So when we do this, our patient's going to lay either supine or prone on the table. My location, we always did supine. We would present a back lock underneath the patient, and we would suck all the air out so it conforms to their body. Their arms are likely going to be up in some type of holder, and where I was, they had like handlebars down by the hand so they could actually physically grip it. And then we will align them with our lasers, which is kind of what this therapist is doing now, but this is after they've done a simulation. So when we first make our marks, we're going to go down the center of the patient and across the patient, and then we'll have two on the sides here as well. So then this is what it's going to look like on the patient's skin with a Sharpie. This patient has also had a tattoo in the center location. We can do that if we need to make more of a permanent mark. Up in the right-hand corner, we do have a prone breast board. This is not something that we did at my site, but I know some places do. It's just like the MRI type system where the breast tissue is going to hang down from the patient and they can image just a little bit more and kind of lengthen out or kind of string out that breast tissue. So it kind of takes the tissue away from each other. They may have a back lock too, maybe like their lower kind of pelvis up into up to their ribs, or they may just have them hold onto the handlebars up here and go from there. The imaging that we're going to get similar to the bottom left. And so with this CT here, we can visualize the different structures. And once we take our imaging, we're going to send it on to the dosimetrist and the radiation oncologist, and they will make a treatment plan. One of the first things they have to do is to outline structures that matter. So the doctor is going to outline the PTV, or the planned target volume, all those areas in there that we want to treat with the highest level of radiation. So that's what they've done here. So kind of this kind of like burnt red kind of color underneath is what the physician drew. And the dosimetrist went in and they highlighted all of the other structures. So we're going to have left lung, we have right lung, we're going to have the different atriums of the heart, and then the heart structure as a whole. And then we also have the spinal cord listed down here. And so from there, they'll decide how much dose will go to the planned target volume and trying to spare the other tissues. Down here in the right-hand side, we can see that we kind of have this weird graph. So what we have done is we have had our patient take a breath in and hold it. So that's what you see here is when they are accelerating up, we're having them take a breath in. This is where they are holding it, and then they're allowed to breathe. And then we're going to have them take another breath in, hold it, breathe. Same thing. So what that does is the system will figure out exactly where in that scan they held their breath, and they're going to use that to help create the motion management of when they took a breath in, where did their chest rise and fall. So we'll do this, and we'll put a little just a little block kind of on their abdomen when they're breathing, because your abdomen moves a lot when you breathe. And so there's a camera that's going to pick up how that block moves, and we're going to be able to track it on this graph as well as the imaging. And so that'll help the dosimetrist create the plan, and the motion management will pick up on how they should be located when they're breathing, and then how they shouldn't be, and what is tolerance for that. So that's what that's demonstrating there. Some examples of our external beam radiation therapy. So in the first image to the left, we have 3D CRT, where we will have tangentials. So our goal is to try and spare as much of the healthy tissue as possible. And so what we're going to try and do is we are going to treat from different angles. So this is just showing you, if you had left and right breast, how we could go about trying to add the angles in there. So from this side, We have a few different angles that are trying to cover the tissue. We could also have some coming from the opposite side up here as well. But it's more of trying to avoid the other tissues, and there's only a handful of beams. Versus IMRT, now we have a crazy amount of beams, right? It looks kind of silly, but we have so many different angles that we could come in to treat the breast tissue. And again, this is showing you all the way around for if you're doing left and right breast. But we can come in from all of those different angles and treat them with a certain amount of radiation, especially if we're doing just like a small tumor bed, then we can just do a small area. Or if we're doing the whole breast, we can treat that as well with IMRT. And then VMAT is very similar to IMRT in the sense that we have a ton of beams. But the thing is that with VMAT on our screen, it only looks like we have one beam because it's just going to deliver the radiation as it moves the 360 degrees around. So we can do this with our breast patients, and we'll just, once we start that beam, the VMAT's just going to start going, and it's going to go all the way around. We don't have to start and stop. Versus every individual one with IMRT, you have to start and stop and re-hit your button to start the radiation. So here we have two different setups if we did IMRT versus VMAT, and they have scheduled out for the whole breast, and they're identifying how much dose is going to be given throughout the entire tissue. And so they kind of have that labeled throughout what they're getting. And then at the bottom, we're seeing that dose volume histogram saying that they're treating the whole breast, our planned target volume, and we're trying to receive 100% of the dose for the entire time. Okay, trying to get as much as we can. And then we see all the other structures that they could be concerned about that they want to evaluate. So our left lung, our left anterior descending coronary artery, the whole heart tissue itself, the right lung, and the contralateral breast. So when we're evaluating that, we can see that they're not really getting much radiation comparatively to what we are hoping to treat. And that is the goal. We want to try and squish all those other organs that are healthy down in that left and kind of left bottom corner if possible. And then we want to keep the treatment area as high and to the right as possible. That means we have a very good treatment plan and good constraints on our dose. And here's an example of what our daily imaging would look like. So on this left picture, you can see an entire CT image. That entire CT slice is going to be from the simulation, okay? So that was back when they did their original simulation. That is the CT they acquired. Now, today's daily imaging, what they have imaged is our cone beam CT, which is very, very round because it's not big like the overall normal CT was for simulation. It's just a small version. So what we're going to do here is we can see that it's more kind of like the ghost or like the shadow over the top of the original CT. So I'm going to outline some structures here in the green of what today's imaging shows outline-wise. Okay, and then I'm going to switch back to my purple and outline what the original one was. Okay. So as you can see, and that purple's not amazing, but where we just imaged with the green, it's a little bit off from where the purple is. So what we're going to do is we get to click up and down, left and right little arrows on your keypad. You get to do that on your computer at your console as a radiation therapist. And you're going to do your absolute best to match things up. And you'll have preferences by your doctor. If for some reason you can't get everything perfect, which area would you like to spare the most? Are you going to line up the spinal cord the most because you're worried about its dose? Are you going to line up the heart the best? Because sometimes your breast tissue just doesn't fall perfectly every day. And so that's kind of what they've done over here on this side. So all they've done is they've shifted the patient into those small little centimeters of accuracy to line it up as best as possible. So we still have the ghost over the top, but you don't see kind of like that doubling effect of anatomy because they are as close as they can to be overlapped. And that's what we want. This means that we're in position so we can treat that tumor. Common side effects of our radiation therapy, of course, the top two are for really any treatment, is they're going to be tired, so they have fatigue. They're probably going to see some erythema at some point, usually not for a handful of treatments will they see the erythema. It kind of just builds on itself, and you kind of get more of like that sunburn aspect. So I have actually on the right hand side an image of this patient. So they had the beginning of their treatment. So they had week 3 of however much treatment they were receiving. And so they weren't really seeing any erythema until week 3. So that's already 10 treatments in. So you can kind of start to see like this line starting to form just a little bit up here. And then you can see some of the redness underneath where maybe that breast tissue rubs after they have received treatment. And then this is their scar from where their lumpectomy was. So then 8 days later, within their last week of treatment, so it looks like they would have had what, between 4 and 5 weeks, 4.5 weeks of treatment. And so up here at the top, you can start to see that it is much more red on this patient. You can see the lines of where our treatment ended and where it started. But the thing with this though is that redness, yeah, it looks like it's sore and not super comfortable, but I have seen a ton worse sunburns. I mean, have you ever had a sunburn that got so red that it peeled and had blisters and boils? Um, those are awful, right? And so our goal is to try and keep it to a minimum of this. So this to me screams that it was a good amount of patient taking care of their skin, us supplying what they needed for cream wise to keep it at a manageable level. Because then 1 month after their radiation, it's almost entirely gone. Obviously, the skin, this is a different lighting and a different angle than what the first picture was, but so the skin may look and feel just a tiny bit different after radiation therapy, but overall, it's not super red anymore. We don't have those issues. So that's what our goal is to try. If we do get a little red, that's okay, but we're trying to avoid the really bad sunburn. And like I mentioned, you can have like a little bit of thickening, so your skin may just feel and look a little different after you've received radiation. That's normal. Eventually, over time, sometimes it will go back to being closer to normal. Sometimes patients will feel a heaviness feel to their breast. So it just feels almost like it's kind of like weighing down a little bit on that side. That usually subsides after a few months as well. We have dry and wet desquamation. These are, remember, where we have the peeling of the skin and it's like cracking. So like when you get really nasty cracked hands during the winter because it's so dry and you've washed your hands so many times, that's more of like what the dry desquamation is. And then the wet desquamation is when you're going to see patients that maybe have a couple areas that rub against each other and it's constantly moist, so like from sweat. And so when we have deterioration to that skin, it can crack and cause more of almost like an ulcer. So that's more of like the wet desquamation. So potential effects that we're going to see is overall that we're more worried about is damage to the surrounding healthy tissues and organs like the other breast, both lungs. We're worried about the heart and the coronary arteries, and we're worried about the spinal cord. And we're also somewhat close to the esophagus in some instances as well. So those are all things to think about. But with our dose constraints these days, as long as you have a good radiation oncologist and dosimetrist, things should pan out very well. Obviously, with having so much radiation exposure, there is an increased risk for future cancers. We really hope that's not the case, and it's really hard to pinpoint that this was truly what caused it, but it can be, a greater risk for that in the future. The second type of cancer we're going to talk about is prostate cancer. So obviously, this occurs in men. And if we're looking at their lifetime chance, it's going to be 1 in 9 that they will have it at some point. And the prostate is going to be a small walnut shaped organ that sits behind the pubic symphysis and kind of just posterior and inferior to our bladder. The risk factors for developing prostate cancer include increased age. So as they get older, it is more likely that they're going to have a higher chance of having prostate cancer, but also that cancer that shows up will be a higher grade, which means it's more aggressive, and a higher stage. So again, how large the tumor is and if there's any kind of lymph node involvement or metastasis with it. The second main risk factor is going to be race. And it seems as though Black males have the highest incidence of this. So they're more likely to have prostate cancer. Not necessarily they're more likely to have the mortality from it, but they just see a higher percentage in Black males. So some anatomy reference here when we're discussing our prostate gland. So first off, I want to point out that we have our pubic symphysis right here. So that is the bony structure down our pelvis, obviously, that we feel for things like doing a KUB. And then right behind that is going to be our prostate gland, which is found here, which sits posterior and inferior to the urinary bladder. And then the prostate is also going to be anterior to the rectum. So this is the rectum back here. One thing that you may see is that if a patient has an enlarged prostate due to their cancer or hyperplasia, it may start to move up into the space between the rectum and the bladder. And so that can add pressure onto either of those structures and cause issues with going to the restroom. So they may have incontinence where they have trouble going, or they may have trouble stopping once they start to go. So that can be very frustrating and debilitating for our patients. But the prostate, its main role is to add additional fluid within the semen. And so with this structure, we can start to see, obviously, with its exit having to go through the urethra, uh, it can cause many issues for these patients, especially obviously with trying to urinate. And so that can be one of the first symptoms for the patients as they start to have issues with using the restroom or extra pressure down there, along with having a higher prostate antigen, which we'll talk about here in a second. Similar to breast cancer, the clinical presentation of our prostate cancer is it's going to be asymptomatic until it finally reaches a certain size and they have issues with urination. And so it can either reduce the flow, it may have to make them go more often, or they may not be able to go at all. Another thing is that they will do a blood test and urine test. And if they find that there's a high prostate specific antigen within those labs that they do, they are going to be able to find that it could potentially be a malignancy. But we also have something that can be called benign prostate hyperplasia. And so that's something that's not malignant, but it can cause your prostate specific antigen to be high. So that's another thing that they'll consider. They'll do a biopsy, all those things to evaluate and decide if it's malignant. Along with that prostate specific antigen, which I spoke little bit too fast about on the last slide, the level should be about 4 ng per milliliter or less. And so that should be a very low number. As it's starting to rise and it's getting to like the hundreds or even higher. There's a greater chance of having cancer. But as I mentioned, you can't have that benign prostatic hyperplasia. It's completely benign, no cancers involved in that. But they still want to try and get that under control too, so that way it doesn't add pressure into trying to urinate. They also can do a digital rectal exam. And so this is where they are going to insert fingers into the rectum and feel for any kind of bumps or enlargements, because they would feel if that prostate is getting very large from the cancer. So a lot of men, once you get older, they're going to start doing at your regular healthy checkups their rectal exams. I know it's uncomfortable for people, but it's something that could potentially save your life if it's going to help find that you have prostate cancer and get you treated early enough. Same thing that goes back to the breast cancer, the different types of things we can do to help evaluate our own breast tissue and have a good baseline is important. Even though it is uncomfortable and it's sometimes it feels embarrassing for the patient, but healthcare professionals they do that kind of thing all day long. They don't think anything else about it. They're just there to make sure that you have baseline and that you are healthy and get you the treatment that you need if necessary. For biopsies with prostate cancer, they are going to do core needle biopsies, and this allows them to take multiple sections out of the prostate because sometimes they want to evaluate the entire prostate to see if there's anything else kind of moving throughout it. It's not quite the same as with breast cancer where you have the lobes or the ducts where it could be within. The prostate just it really is a hunk of tissue, and so they want to evaluate multiple sections throughout there. And this is done by a urologist, and so it's typically done in their clinic type setting. And with the biopsy, they will sometimes have to bring in an ultrasound tech, but a lot of times they have devices nowadays that the probe is built into the needle guidance. And so they'll use ultrasound. I have heard of them doing MRI if needed, but they'll place this probe either transrectally, so up through the rectum to gain access closer to the prostate, or they'll do it transperineal, which is just right outside of the skin. It's going to be posterior to the testicles, but anterior to the rectum, and they will insert the needle that way. I will say that is much more of, I'm going to say the word invasive, and some of you may not think that that's the correct word, but invasive meaning that they have to go through more tissue. And so when they go through more tissue, there's more chances of infection, having more complications and issues there, versus if they go through the rectum, which obviously many people are probably hearing this and thinking that's very invasive. It is more an invasion of privacy, and it seems much more uncomfortable for the patient. I mean, all of it's uncomfortable, right? But when they're able to place that so close to the prostate, there's less tissue to go through, and they usually can get done quicker. So that's kind of the difference between the two. But obviously, there's pros and cons to both. Your urologist would probably walk you through whatever you needed to do. When they do their stage of the cancer itself, a high majority of them are called adenocarcinomas. And so they're just a certain particular type of cell. We give them what's called a Gleason score. So typically they are grades 1 to 5 based on what their cells appear like. So they look very similar to what the surrounding cells look like, or are they just very, very different? And then based on that findings and what they saw, they may even add them together and they'll say, oh, they have a Gleason score of 4 plus 5. That really doesn't matter all that much to us as radiation therapists. We just know that the pathologist has really done a lot with scoring the patient and the aggression of it. So that way the doctor can determine what is my best protocol. Do I take it out? Do I just do radiation therapy? Do we do chemo? What is the options? But one thing about prostate cancer is it is a possibility that it could spread to your bones. That's a common one. Your liver, lungs, and your brain. So they want to make sure that they evaluate this, and then if they need to look for metastasis, they can do that. So this image here is showing you your transrectal. So they have the ultrasound probe with the needle biopsy along with it. So you have your rectum, you have the probe that's coming in to identify where the prostate is, which is right here, and then the needle will come in and they'll take multiple of those biopsies to confirm if there are cancer or not within there. The thing about prostate cancer and its treatment options is that prostate cancer is typically a pretty slow growing disease. And so when patients find out that they have this, if they are older patients, and I'm talking like 75 years or older, they may do what's called watchful waiting. And so they may see how it progresses as they're getting older and decide if treatment is necessary. Because at that 75 years of age, they may say, okay, well, if I get treatment, what's my quality of life? Is it going to be worse after finding it if I have to get my prostate taken out? And what about radiation therapy? Is that going to affect my ability to use the restroom? So there's a lot of things that they have to evaluate and see what they want to do. So watchful waiting is one thing. They can do a radical prostatectomy. And so this is where they're going to resect or take out the prostate cancer, and it's going to be confined just to the prostate as long as they are in good general health. And so with this, we want to make sure that they have at least a 10 years or more of life expectancy. If it's less than 10 years, we'll go back to kind of that watchful waiting. But if they have at least 10 years or more expected to live, we want to try and give them the best opportunity to have a good turnout and exceed hopefully those 10 years. Hormonal therapy, so that's going to be halting the proliferation of prostate cancers by cutting back on the supply of testosterone. Just like with breast cancer, some of these types of tumors will feed on hormones. So if we can get rid of the testosterone, it may like inhibit or prevent the growth of that tumor. Chemotherapy is an option. I would say chemo for prostate cancer is not as common. If they do it, usually has to be a couple different types of systems within there, and then they're pretty specific types of medications. Um, but I've had several people that have had prostate cancer that I have known as well as having treated them, and they only had to have surgery and rad therapy, and that was it. A couple of them did have to have chemo, but they were pretty aggressive diseases. So obviously radiation therapy, we can do external beam in a variety of formats, and then we can do brachytherapy. Again, this would be interstitial. So they would be putting some of those radioactive sources within the prostate. So they can do prostate seeds. They can also do where they just place a radioactive source and they take it out in the same treatment. Um, I believe there are some treatments out there that are not as common that they can just bring it within the rectum and just place it close to the prostate as long as the prostate's like right there. And they can just not have to go truly through a tissue. It's more of that intracavitary. So, a couple options there for patients. We do often have to do some separate preparation for radiation therapy with our prostate cancer patients. And so, what we do is they will place what we call fiducial markers. And so, this is going to be small seeds about the size of rice, maybe a tiny bit bigger, that are placed inside of the prostate. So, typically, when they do this, they'll try and get both of these options here at the same time done if they need them. Those fiducial markers are going to be a really good alignment piece for us. So when we go to do our daily imaging, we can find those fiducial markers from their simulation and then also from the day that we're imaging, line them up to be as close and know we are within the prostate as best we can be. The other thing that a lot of patients will get are called spacers or space OARs. And so it's saying we're putting space for the organs at risk. So what we do is there's a water-based hydrogel that they will place anterior to the rectum. So it's this little space between the prostate and the rectum. And so what that does is it adds an additional little layer that's going to help us find where that spacer is, where the outline of the prostate is, and then where the line of the rectum is. And so we will reduce the amount of total dose to the rectum because we can make sure that we are not treating it. We're further away, or we're only giving it so much radiation dose. So over here on the image, we can see both of those. So this is going to be a cross-sectional axial image. This is pubic symphysis right up here. So we're very low in the pelvis. Obviously, that's where the prostate is. And then we're going to be able to see this yellow back here is the rectum. And then I'm going to pick a different color for right here is my spacer. So that is the hydrogel they have placed in there in order to prevent their the prostate being too close to the rectum during treatment. And then you can get another color. We have these two bright kind of objects right here, here, and here. Sometimes they do 2, sometimes they do 3 or 4, but those are the fiducial markers. So we can find them on every image that we take to help us align. And then obviously we have the outline of the prostate here. So we are going to do our best to flip back and forth and match them as close as possible. With our treatment with prostate cancer, within radiation therapy, historically we used to do what was called a 4-field box. So we'd have 4 different angles that we'd come in from. We do anterior, we'd come in from the left, we'd do posterior, and we'd come in from the right. This is kind of still a fun name that a lot of people use to name groups. So for instance, on Facebook, yes, I said Facebook, I'm old. There's a group called 4-field box, and it's for radiation therapists and others that are in radiation oncology. And we just kind of share like experiences, and also there's like some funny, videos or pictures that people put out there of just things that happen to you when you work in the area. Just like, you talk about X-ray, CT, MRI. There's certain things that just happen to you in healthcare, like experiences with patients that kind of make you laugh. So anyway, tangent. The main treatments that we utilize, we can use 3D CRT, we can use IMRT or VMAT. Another one that's becoming much more common with prostate is proton beams. So they do have to go to special facilities where they have a proton therapy machine. A lot of normal facilities, especially in smaller communities, will not have that proton beam therapy. So patients will have to travel hours or across state lines to get to these. One thing that is a little bit more challenging about prostate cancer when compared to other treatments is that we require our patients to have an empty rectum and a full bladder, which is a lot harder than you might think. Um, because we typically try and get our prostate cancer patients done, around whatever time they normally have their bowel movement. So if they have their bowel movement right in the mornings pretty regularly, then we'll try and schedule them after that normal time. And when they come in, we need them to have had their normal bowel movement. And then we also need them to drink several glasses of water. So what this is going to do is it's going to allow for consistency when we are aligning our pictures for the day and our beams. So increasing the size of the bladder pushes things back, but we have that spacer behind the prostate and in between the rectum. So that's going to help give it that direction. And so it is challenging, especially later on in their treatment. They may start to feel like they're losing a little bit of sensation down there. And so they may say, oh, I feel like I'm full. And then we'll scan them and their bladder has like nothing in it. So can be some challenges for those patients, but overall, they usually do pretty well. The radiation oncologist will determine the treatment margins and then how much dose they want them to receive. So about 7,800 centigrade is common for total. And then per fraction, they're going to get about 180 to 200 centigrade. Hypofractionation is an opportunity where they are going to receive about 7,000 centigrade and we increase the daily dose. So their daily dose might be delivered up to 250 centigrade rather than that max of 200. They will decide what type of treatment they want. So again, 3D, IMRT, VMAT, or brachy. And then we could also use motion management within this if we wanted to. Some places just do that on natural instinct, and then others, they kind of shy away from that motion management. So really just depends on your facility. Here was an example of a treatment with prostate cancer. So they had a mid to low Gleason score overall, and it was adenocarcinoma of the prostate. They used IMRT and they treated both the prostate and the seminal vesicles just based on all of their imaging. They felt that was most appropriate. They did 7,800 centigrade delivered in 39 fractions. And the plan was to do daily imaging with CT. And they did about 7 to 9 fields, depending on where they were at. And with the image guidance, they were able to align their fiducial markers and help them place everything. The rectum, bladder, and the femoral head were all concerns for them. So they wanted to make sure the dose was under a certain level for those, and they were able to achieve that. Here's another example of a prostate cancer patient. They did have low risk or low Gleason score prostate cancer, and they received low dose rate brachytherapy. They did do prostate seeds where they inserted them and they put them in transrectally with ultrasound, and they received about 12,500 centigrade to 14,500 centigrade. And so this is insane, right? You're thinking, wow, you just told me it's a low dose rate. But when they were looking at this, brachytherapy is actually usually a lot more than that. It's a very, very high dose because they can get so close to the tumor itself. So when they put these in there, it is a higher dose. And they use it's iodine 125, or they also could have implanted palladium 103 seeds. This was kind of like part of a bigger research study, so that's why there's the variation. Some of them got one, some of them got the other. And they tried to make sure that the urethra and the rectum also did not get too much dose, and they were able to meet that. Those seeds they implanted transrectally, they only stayed active. They usually are about from 60 days to 3 months, so about 2 to 3 months. And so they usually tell patients that up to that time frame, maybe don't have kiddos or pregnant women close to you or sitting on your lap. And then after that time frame, they're no longer active, so it's totally fine. But just while they are implanted, you try and avoid some of that. So here we have the simulation process for our prostate cancer patients. Obviously, the patient that's laying on my table is not male, so they don't have that anatomy within there, but it's a therapist trying to demonstrate what we would do. So we have our patient laying supine. We're going to build a back lock around their lower legs, as well as sometimes it even goes up into their pelvis a little bit. But we're really worried about their legs. So I want you guys to think about to x-ray. When you take a pelvis x-ray or an AP hip, what do we do with the foot in order to change the location of the femoral neck? We turn it, we turn the foot. And so we're trying to prevent the femoral necks from rotating too much in the sense that we might be out of the range from what we're trying to deliver radiation to. So how do I even know that? So when we go over to my left hand picture of an actual CT, this is your femoral head, okay? But then we get a little bit lower and we'll be into the neck. So as we change the location of the femoral head neck, that's going to alter where our angles of our beam are going to come in and interact. And then just like we would with our breast patients and any other type of cancer patient, we are going to set up our lasers to be on top and both sides of the patient, and we will identify those locations and create crosshairs. So again, I just brought the same picture that I did from the breast cancer patient. We just line up to where our lasers are. With this, depending on how you have the patient's leg set up. So if you're in the back lock right now and you need to keep your patient's legs still, what we used to do at my site, because we didn't have like a fancy leg holder, was we would put a sponge block vertical in between their feet. So think the long ways going along the length of the feet. We place it between their feet, and then we put a rubber band around their feet to help hold them within that same position so they couldn't move. Some places have a fancy foot holder, and so they'll do something like this, and then they'll just put the back lock more underneath like their pelvis and their upper back. So that is an opportunity there. This right here is called a diving ring. So it's just like what you might think of as kids at the pool, throwing out the rings and going down and getting them from the water. And there are like actual ones out there that are manufacturer made that you don't have to buy. That's a pool ring. But if you don't want to spend very much money in your department, you can just get a diving ring from what the kids would play with. And so why do we have that? That is for our patient's hands. Because when you're laying on your back, depending on how big your chest is, and some of the guys have big barrel chests. And so we don't want them to put them down by their side because that's going to be in the way of potential beam angles. So we want them to keep them up on their chest. And if they want something to hold on to so they don't forget that they can't put their hands down, we'll give them a diving ring and they'll just hold it in between their hands on either side. So that way they are holding on to something. It's a reminder I cannot move my hands down by my side. And if somebody can't even reach their hands across their chest, then they can use that. So here are a few examples of what we could use for IMRT and also what we can do for VMAT. So up here at the top, all of these different colors that are within the pictures are demonstrating where the planned target volume is, what the rectum is, the bladder, and the femoral heads. So when we image first up here at the top left, we're seeing an 8-beam IMRT. And so they're coming in from both sides in order to get the dose to that prostate. They move over to the right side of that top area, and they're doing something similar. They're coming at just a little bit differently, but it's very, very similar to what you see on the first one. Then we have a 24 beam at the bottom left for IMRT. And as we're doing that, it's very much conformed, and you can see how we are starting to get less and less dose to the surrounding structures. And then the volumetric arc therapy in the bottom right, you can see how very little dose is being given to surrounding structures there. And so it's very conformal. These are all options that are okay and possible for the dosimetrist to come up with. And then they would have to decide what's the best possible that we could do and then present that to the radiation oncologist. Here we have the dose volume histogram for the prostate cancer, and with that, the planned target volume is the blue. So we are giving it as much possible dose to all of it as we can. That orange kind of color is the bladder. So obviously we are very close to the bladder. We don't have an additional space between the bladder and the prostate. And so that is getting quite a bit of dose. But the bladder has a higher TD55, so a higher threshold, and especially when you're only treating a portion of it. So that is acceptable here. Then we have what's going to move down to the femoral head and the femoral head on the right side. So both those are going to be in kind of the red color. And so both those are fairly low. And then we've got the rectum is the brown. So that's kind of the next underneath the bladder for the total amount of dose that they're going to get. It's a little higher than they probably would like. So the dosimetrist may work this again to try and get it even further down. They're just trying to give it as little a dose as possible. So we don't have to worry about some issues with the intestines, because we have a lower TD55 and a lower threshold for the rectum. It's 45. All of the intestines, all of that generic area is typically around 45 before we start to see some not so good side effects. Here are some CT images of the day that we are trying to treat the patient and what we are aligning to. So the purple and purple fuchsia color, I'm not sure why they made it a certain color, but this is representing the original simulation CT, and then what's kind of in the true, what I would think of as imaging color, so more gray. It has like a little bit of a green tint to it for some reason. That is what our cone beam CT was able to acquire for this patient. So we are lining up the AP version, trying to make sure that we get our structure where it needs to be aligned. We move to the lateral portion. We can see the rectum. This is the bladder, and then here's the prostate, and we're making sure we're centered. And then the bottom left picture, we're seeing the axial images. So pubic symphysis is here. We are below the bladder at this point. So we are at prostate here and then rectum back here. So we're just going to do our best to modify and get the patient set up the way they need to be to give them the correct amount of dose to each structure. Most common side effects from prostate radiation therapy, number one, just like with breast cancer, is going to be fatigue. They get very tired. They may experience some rectal discomfort, especially if they don't have a spacer. We can see that they have incontinence or increased frequency of urination, and that's just due to the fact that we are treating some of the cells in that area. And too much dose to the urethra and to the bladder can just make your sensations feel a little bit different with your nerves. Kind of back to the rectum area, you could have diarrhea, the upset kind of issues with using the restroom. They could have some abdominal cramping if there's a lot of dose, and they're very sensitive to that. But other outside potential effects that we could see is damage to the surrounding healthy tissues and organs, obviously, and then increased risk for future cancer. So, with that being said, again, it's hard to kind of bring it back and say this is what caused another cancer in the future. But having had this, it is a good indicator that they had something that was carcinogenic. So, which is the ionizing radiation to this area. But a lot of patients have really good outcomes with radiation therapy with prostate cancer with very little reoccurrence.